So I'm just going to pause it. Zoom record. So whenever you're ready, Cory, we're good to go.
Excellent. Guys, I want to thank you very much for joining this call. Normally, this presentation is going to go a lot faster than what we're doing on this call because there's a lot of information in this presentation that is not necessarily imperative for you guys to know on the field or on the floors, but we're going to go through it since it's here and it's being recorded. So this is the Tempo temporary cardiac pacing lead. It is a new temporary pacing lead for the Hopkins system. And we just want to make sure that any personnel who are involved in working with the lead post-procedure should be familiar with how to remove the lead. And that'll be at the tail end of this presentation, which is really what you guys are going to be involved with knowing. But I just want you to be familiar with the rest of it as well. Tempo is the only active fixed temp lead on the market. There was one that was on the market that was a screw-in lead for a temporary. A lot of hospitals have used permanent leads that would be attached to a pacemaker that's implanted in the shoulder. As temp leads, we're not talking about those. We're talking about actual true temporary leads. It has some structural differences, but those two differences, if you look at the very distal end of the lead in this picture, so the lower right-hand corner of that picture, that's a soft, flexible silicone tip. So that's designed to mitigate the risk of perforation that is present with the other temp leads. And then just proximal to that, you'll see the two black loops. Those are nitinol rings that come out kind of like cat claws, getting the coming out of a cat's paw. Those are designed to lock the lead to the RV septum to keep the lead from moving, thus keeping the lead from losing capture. And I know for you guys who have taken care of temp leads on the floor, I'm sure you have never, ever seen a temp lead ever lose capture. So this lead was designed by a cardiologist team from Stanford who were tired of sending their patients to the OR for perforation risk or valve embolization, what have you. So it does work well. It was designed for those two structural changes. I will say because the lead does lock down, the patients actually can be ambulatory even in complete heart block with this lead, and that has been used nationwide in some large hospitals. And I understand that Hopkins is interested in sending patients to the PCCU with temp leads. So this is a step forward for both sides, I guess. So if you look at the lead, it is a bipolar pacing electrode, so it's no different than the lead you guys are using to date. It does have standard connecting pins. The lead does come with two adapters that will slide in to those adapter pins, which I can show you later. That just ensures that this lead can connect to any extension patient cable that connects the lead to the pacing box. So that way that there's no limitation from that regards. The lead is a 6 French lead. It will fit through a 6 French sheath. We've talked to the lab and they are aware that we do recommend a 7 French if they don't have a 6.5. Most hospitals do not have a 6.5 sheath. The big thing for you guys though is this lead cannot be floated bedside. It must be done under fluoro. So that's a little bit of a difference compared to the lead you guys are using to date. But the benefit is that, again, once this lead is positioned, it's not going to move. From over 12,000 cases to date, we have a loss of capture rate of 0.02% and a perforation rate of 5 out of, like I said, over 12,000. The other temp leads have a loss of capture rate of between 10 to 37%, so we are significantly lower than that. And then a perforation rate of about 1 to 1.5%. And like I said, we're 5 out of over 12,000. So the safety is clearly proven. It just, you can't float this lead bedside. If you look at the lead, it does have a distal electrode, a proximal electrode, and then proximal to that, further up the handle or towards the handle is what we call our orientation marker. That's a band that they can use in the lab under fluoro to make sure that the lead is facing the right direction. The lead also has a balloon, which I don't think you can necessarily appreciate in this picture, but the balloon is on one side of the lead body and the stabilizers are on the other. The balloon's purpose is once the lead tip is in the RV apex, the balloon inflates to push the lead up against the septum, deploy the stabilizers, and then the balloon is deflated, which means when the patient hits your unit, that balloon should be deflated. A stress should. So you may want to check with the doc if that balloon is inflated, and you can tell by the syringe. But just our recommendation is the balloon should not be inflated, because you want the lead to be anchored down with the stabilizers. Because if for whatever reason that balloon were to rupture and that's what was giving low thresholds, then all of a sudden those thresholds are going to jump up, and we want to make sure that the patient is well protected by relying on the stabilizers and the stabilizers only. You can see in the cartoon here that the balloon is on one side of the lead up against the free wall, and the stabilizers are locked into the septum on the opposing side of the lead. Look in the lower right corner, you can see under fluoro and RAO, for those of you guys who know fluoro, that's what the divot looks like, and that's what tells us that the stabilizers are truly facing the septum. The reason why that's important, you look at the cartoon, the free wall at the apex can be very, very thin, and we don't want those stabilizer rings locked into thin tissue on patients who could be, I guess, compromised anyway. We want it locked to the septum. So the lead does come in two different configurations. We have one that's for femoral and then one for IJ. As far as the function of the lead is concerned, from the floor standpoint, it is the exact same. They're the same length, same function. The only difference between the two leads is one at the end is curved to the left, and the other one is curved to the right. So again, on the floor, that makes no difference for you guys at all. The lead can be, or is indicated to be in position up to 7 days. I can't condone leaving the lead in for longer than that, but I can report that there are physicians who have left it in a few times to 11 days, and once, to my knowledge, up to 18 days, and they were able to retract this lead with no issue. Again, we don't recommend that, but I'm just reporting the facts that we are aware. So you can see the adapter pins in the right side of the slide. They'll slide into the actual pins, I guess, on the lead itself. So it's best not to need those pins if you don't need them. But again, being that the lead would be positioned in the lab, that should already come to the floor with everything connected. So you guys shouldn't have to worry about those things. In the event that the lead obviously does become disconnected or whatever, certain physicians will say one thing, certain physicians will say another. From my experience working in EP, it does make a difference for some patients. You do want the positive connect to positive and the negative connected to negative. It's best not to cross those. So just some patients are more sensitive to it than others. And again, because of the connecting cable, it will connect to any external pacing generator. We did have cases at Hopkins about last month, I guess, well, not last month, it was August, now that we're October, but they used it on alcohol septal ablation. That patient was in the CCU. We walked into the unit, the patient was sitting in a bedside chair, incomplete heart block, and then Dr. Rosari used it in 2 TAVRs that Friday. First patient needed it post-op, second patient did not. But either way, he was very impressed with it. Hence the reason we're having this call. So for the simple lead training goals, obviously we want the lead positioned safely into the distal or distally into the RV apex. Stabilizers deployed in the septum. All this is to obtain adequate low thresholds. And then for you guys, it's important. We just want you to make sure that the lead is straightened prior to lead removal, and I'll talk about that. Again, these steps are not really required for on the floor, but we'll just go through it. They'll test the balloon to make sure it inflates and deflates appropriately. They'll test the stabilizers they deploy and retract appropriately. Their lead is shapeable at the end, so that way it enables them to get the lead in the apex well. Moderate overshaping is recommended, but again, that's in the lab. And then after shaping, they do test, or should, test the stabilizers and the balloon again, just to make sure that everything works the way it's supposed to. So again, the IJ and the femoral lead, the exact same lead, just when you're looking at them, one's curved to the right and one is curved to the left. Other than that, they're the exact same lead. All right. And actually, we can skip this. For lead insertion, they'll make sure the balloon is deflated, stabilizers are retracted, they'll advance it into the heart. Ease passage, they should use, there's a little introducer, which is like a sleeve that may or may not come on the lead when it comes to your unit. If it does, I would verify with the physician, but you guys really can't do anything with it. It's just one more thing to get in the way. So that little sleeve, what we call the cheater or the introducer aid, is just a molded piece of plastic. It'll just pull straight off to the side of the lead. And I don't know if I have a picture of that in here. No, I don't have a picture of it. Sorry. But
Cory, are you
if I,
familiar with pulmonary artery catheters at all?
I'm sorry, say the question again.
Are you familiar with pulmonary artery catheters?
I am, yes. So
Okay.
those have the cheaters on them as well.
The what on them?
Those have the cheaters on them as well,
Cheaters.
just to reinforce them. The little introducer aid,
Okay.
the little sleeve.
Yeah, that's what I was trying to figure out, if you're talking about the same thing that we call a like a sterile sheath over top of the wire.
So the cheater is a little bit different than those. We do recommend that they do use those sterility sleeves with Tempo as well.
Okay.
They did use them when we were there. The cheater is nothing more than a short tube or kind of a pipe, I guess, with a handle that sticks off the side. The whole thing's about 1.5 inches long. Its goal is to reinforce the flexible distal into the lead just for them to gain access into the sheath, because the sheath obviously has a hemostatic valve across it. But the docs can point these things out, and we're going to be there not next week, but the week after, and with my demo product, so I can walk around it and show you guys very easily how this thing works. So don't worry about that.
Okay. So
Excellent. So they'll advance the lead into the RA. We then recommend that the balloon is deflated. They'll advance it to the RV apex. They'll check the orientation marker to make sure that it's facing the correct direction. Inflate the balloon, deploy the stabilizers, and then again deflate the balloon. So again, all that's in the lab. So long story short, here's what it looks like actually in the patient. So clearly you can see in the left image that is a Sapien from Edwards TAVR valve with the lead. From my, I guess, layman's approach, I would like to see that lead a little bit more further distal in that patient, but clearly it worked. But you can see the little cutout C marker on the top right picture, and then the two actual pacing electrodes, and then with the balloon inflated, you can kind of see the lighter white circle of the balloon around the lead. But again, once the lead is locked to the tissue, we do recommend deflating the balloon so it's not inflated on the unit. All right. As I said, they should deflate the balloon, check the pace capture threshold to ensure that it's within an acceptable range. Our data shows that our average threshold is 0.7. They had a standard deviation of about 0.5, 0.6 plus minus of that 0.7. My personal litmus, if it's 1.0 or less, I'm happy with. If it's above 1.0, and Dr. Rassar seems to agree with that, is I'd recommend repositioning the lead. And the name of the game, or I guess the purpose of all that, is to make sure that if the patient does need the lead post-op, that it's going to work as it should. So having those low thresholds keep the stress level lower there on the recovery units. So I'm going to, again, educate the physicians to make sure that they do not accept a high threshold for this lead. But for lead removal, this is where you guys come involved. I don't think that your staff is going to be necessarily involved in actually pulling the lead, but we know that there are a ton of physicians who would like you guys to be aware. If the lead is left in, whether it be femoral or IJ placement, we do recommend that the excess length is coiled up. The handle is I guess, tucked on top of that coil, and the whole mass is covered with a dressing. You can either use Tegaderm. A cheaper option would just be use gauze and some paper tape or something like that. It just keeps everything from getting snagged on the bed sheets, and also keeps the patient from being able to play with their newfound toy. As you can see on the handle, there's a slider thumb mechanism. If it's slid to the right in this picture, that's with the stabilizers out and locked to the heart. If it's back and then down in this picture, kind of in what I call the safety position, that's the stabilizers retracted within the lead itself. So we just want to make sure the patients don't have access to that slider. There are some patients that, even if you talk to them, they're still going to play with whatever they can find. So we just want, I would recommend having that handle covered under the dressing to make sure the patients can't get to it. But with the lead coiled, as we discussed, in 3 or 4 inch diameter coils, there's a lot of friction between the stabilizers and the lumen, I guess, inside that lead. So by uncoiling the lead, it doesn't have to be arrow straight, but just uncoiled. It just makes sure that when you retract the stabilizers, that motion is transmitted to the end of the lead to fully retract the stabilizers themselves. In the event the stabilizers won't retract, or they retract only slightly or whatever, they're designed to back out of the tissue that they went in. And I wish I could show you that at the moment, but just know that even if the stabilizers are locked in the tissue and you tug the lead, they're not going to biopsy the heart. They should back out of the channel in which they went in. So it's not horrible, but obviously it's not ideal. We actually do want the lead straightened out and then the stabilizer retracted before gently retracting the lead. So pull it like a temp lead, not like a chest tube. Post-procedure recommendations. This is just what we have recommended. Obviously, secure the external portion of the tempo lead. As I said, the 3 to 4 inch diameter coils, and then cover that and the handle down under a dressing. We would recommend checking the pace capture thresholds daily, but it's whatever you guys do for your own hospital policy. The lead does have graduations every 10 centimeters along the lead, just to chart the depth to make sure that the lead has not been accidentally retracted. I know with the sterility sleeve, it can make it a little more difficult to see those numbers, of the striations or the stripes, but they are there. And then again, we recommend having the balloon fully deflated and the stopcock in the closed position. We talked to your nursing administration when we were there, and I don't remember what they said. I think they wanted the stopcock on and the balloon left on for right now, but the balloon would just be evacuated of air and then reapplied back to the stopcock. But if that's the case, that whole balloon lumen with the stopcock and the syringe can also be tucked under that dressing. So it's one less decoration hanging down from the patient.
Yeah, that's what we do with our PA catheters as well.
Excellent.
The syringe stays on, it stays attached, but locked, and we make sure it doesn't have any air. Is there a lock on the syringe for the
No,
tempo?
it is literally a standard 3 mil syringe.
Okay.
So, but if you could tape that under the dressing, then there would be no access to it, but there is no lock. The stopcock, which you can kind of see in this lower right image, is just a standard. It's a 2-way stopcock that's in line between the syringe and the lumen to the lead.
Okay.
A lot of other hospitals, and we can approach this as you guys get familiar with it in administration, if they allow it, but a lot of other hospitals have allowed us to remove the syringe and stopcock altogether, and then they just cap the port with the red cap, and then just place that under the dressing as well. Because again, you guys should not need the balloon again on the floor. Because if the balloon does need to get inflated, then it's because the patient needs to be going back to the lab. And I'm pretty sure they have syringes in the lab. But again, just not to overstep administration, as you said right now, just turn the stopcock off and evacuate the syringe and just leave it as it is.
Okay.
There is a sticker on the outside of the peel pack that obviously by the time the patients get to you, that peel pack is already been put in the trash. But we recommend, and we've already mentioned this to the lab, we're going to mention it again, that sticker can get removed, and it just should remind them that they need to straighten the lead and retract the stabilizers prior to removing the lead. The red text on the sticker and this image has been updated. It now says straighten lead and retract stabilizers prior to lead removal. So it does remind you to straighten the lead. They can either put that around the lumen of the lead itself, as you see in that image. My personal recommendation is to literally just either cut the sticker in half or affix the whole thing onto the dressing that covers the lead handle. So that way it can't get missed. But I'll do whatever you guys think needs to happen. And obviously you guys are going to have conversation amongst yourselves about all this. But it's just a reminder for the physicians that, or whoever's pulling the lead, to straighten the lead and then retract the stabilizers prior to lead removal.
Okay.
All right. If the lead needs to be repositioned, like I said, we cannot do it under or bedside. It has to go back to the lab under fluoro. Again, the risk of that happening is 0.02%, so it's very low. If it does happen, the official company line is the patients need to go back to the lab. I think that you guys should probably have a conversation with the physicians because things do happen on the floor, and obviously you need to protect yourselves and protect the patient. My personal opinion is that you guys might consider is if the lead is not functioning the way that you think it should, inflating the balloon isn't going to hurt. But it very well could make the lead make capture again if the lead did lose capture. But if you do inflate the lead, then the patient should be going back to the lab to check position. But again, I'll leave that with you guys. They can use either air or CO2. I have never seen anyone ever use CO2 with this lead. Air works just fine for it. The syringe that's on the lead is a 3 ml syringe, and that's the volume of air that the balloon will accept per the IFU. So you can give the full 3 ml and it'll be just fine. In the presentation I sent to you, there is a link. I don't think you can actually click on the link because I think I sent you the PDF version. But what I can do is I can copy this link and send the link over to you in your email, Tanya. But it's a 1-minute 20-second video of how the lead actually gets deployed. There's no audio, it's just visual, but it just goes to show how the lead actually does function. But anyway, that is the last slide, other than we have our CMO and myself. If you have any questions, please feel free to reach out to either one of us. My official title is the clinical manager for BioTrace. We do have a local rep there, but as of right now, there's some administrative decisions, and she will not be in the hospital anytime soon. So as of right now, I'm the one functioning as your point contact for the hospital. I live in Dallas, Texas, so obviously it's not quite me walking across the street to get to the hospital, but I will be there as often as I can, and I will do anything I can to support you guys. So you've got my email address and my phone number. Please feel free to reach out to me if you ever have any questions, and I do mean that at any hour. I've taken calls at 2 in the morning before from hospitals. That's my role. So I just want to make sure that anyone who has questions can get your questions answered. Other than that, that is all I have. Does anyone have any questions?
Thank you so much, Cory. So I wrote down a few things, but I think you already answered most of them. Hang on, I'm looking real quick. So one thing I guess would be, you mentioned the usual thresholds that you see. What are, is there like a usual or a range of settings that are usually used? I know you're not the generator side of things, but.
So as far as the heart rate and output and sensitivity goes, it's literally the same as what you would normally use. So heart rate, if you're using it as backup, a lot of docs will use, let's say the patient's running at 60, they'll set it at 40, 45, 50 beats per minute. If the patient is 100% paced, then typical 70, 80, something like that, whatever the patient needs. Sensitivity is typically 5 to 7, but again, it's no different than what you guys would normally use. A lot of other hospitals are not quite as comfortable with setting the sensitivity. So if they're 100% paced, a lot of hospitals will just turn the pacing box to asynchronous to just remove the sensitivity altogether to make sure it's going to pace. For the output, it depends again on the physician. I've seen some hospitals where they set it at 5. I've seen others where they set it at 20. So it's whatever you guys normally do. Is obviously you want a safety margin because you expect some edema at the location of the pacing connection to the tissue. You just want to make sure that edema is not going to cause an issue. But again, our threshold, even at 2 days post placement, may have gone from 0.7 to 0.9. So even setting the output at 3, the patient should be fine. But that's completely whatever the physicians and hospital policy says to do. So I don't want to overstep what you guys normally do. This lead is strictly a pacing lead. It's an extension cord. There's no circuitry in it. So treat it the exact same as far as your pacing box, is concerned, the same as you do for any other temp lead.
Okay. And then one other thing was you mentioned that we wouldn't start next week, but the week after.
Correct, yes.
So originally I thought we were starting the week of the 4th, but you're saying it will be the week of the 10th.
Yes, we were waiting to hear about cases. I actually still have not heard about cases. So at this point, I'm flying out there not next week, but the week after to go through and do training there at the Hopkins and then the 3 outlying hospitals, so Bayview, Suburban, and Howard, just to make sure that all of those teams are up to speed. I have no idea when initial cases are actually going to occur.
Okay.
So at this stage, we just want to make sure that you guys have what you need. So that way, if I have to duck in, cover a case, and then duck out, then I don't feel bad for sliding you guys. But I have to go to New York to do some cases and training next week, which is unfortunately why I can't be there next week. But if things change, I will do what I can to circle through. While the other 3 hospitals are important, we know that Hopkins, Maine is kind of the flagship for this product. We just want to make sure that things go well there before it goes to the outlying hospitals.
Okay. Sounds great. We learned a lot. So
Excellent.
thank you very much.
Thank you very much.
And
All right, we'll talk to you guys.
recording, and then I'll talk to you on email.
That'll work. Appreciate it.
Thanks.
Thank you.